Hello and welcome back to Zoology 141. Today's lecture is going to be on joints. So after you complete today's lecture, you should be able to classify joints using both the structural and functional classifications discussed in lecture. You should also be able to recognize and identify common types of joint movements, and these include things like abduction, adduction, flexion, extension, and so on. You should be able to describe the general anatomy and mobility of the 6 types of synovial joints. And you should also have a more detailed knowledge of the anatomy and function of the hip, elbow, shoulder, and knee joints. You should be able to list the factors affecting the range of motion of joints. And you should also be able to describe the causes and treatments of common joint disorders and injuries. So first off, we should start out with a simple definition of what a joint is. So a joint is basically a connection or articulation between 2 or more bones. Now sometimes this joint might be mobile, and sometimes it might be immobile. And joints are classified in 2 different ways. First of all, we have a structural classification, which is based on the anatomy of the joint, what tissues are involved, and we also have functional classifications. The functional classification has to do with how mobile are the joints. So we have some joints that are very mobile and some joints that are not mobile at all. So as I said in the last slide, the structural classification for a joint is based on the material that is used to bind the bones together and also the presence or absence of a synovial cavity. So structurally, joints are classified into 3 categories: fibrous joints, cartilaginous joints, and synovial joints. On the other hand, the functional classification of a joint is based on its degree of movement. So immovable joints are things like synarthroses. Syn means together and arthrosis means joints. So this is a non-moving joint, a joint where we have 2 bones which are essentially fused together. There's also slightly movable joints, and these are called amphiarthroses, slightly movable. And finally, a freely movable joint would be called a diarthrosis. And examples of diarthroses are things like your elbow, your knee, and so on. So let's start out with some of the structural classifications. So one of the first structural classifications for joints were fibrous joints. Fibrous joints are joints that lack a synovial cavity and where the bones themselves are held closely together by fibrous connective tissue. And usually this fibrous connective tissue allows no movement or maybe just a little movement. And so there are 3 different types of fibrous joints that we would find in the human body. And these include things such as sutures, syndesmoses, and gonphoses. Now, sutures are something we've already talked about. These are the junctions between the bones that make up the cranium. For example, the frontal and the parietal bones are held together by the coronal suture. And so the sutures themselves are held together by tight fibrous connective tissue. In adults, these sutures are fused, they're non-movable. Another example of a fibrous joint is a syndesmosis. And so a good example of a syndesmosis is the fibrous interosseous membrane that we find between the tibia and fibula and also the radius and ulna. Now in the tibia and fibula, this is usually a fairly immovable joint, whereas in the radius and ulna, the sheet of connective tissue is large enough to allow some movement. And then finally we have something called a gomphosis. A gomphosis is a peg in hole architecture, and we tend to find this in the jaw. So the teeth are held in the jaw by fibrous connective tissue ligaments called the periodontal ligament. And normally, teeth are not supposed to be mobile. They're supposed to be entirely immobile in these bony sockets in the jaw. However, what can happen if somebody gets periodontitis or gingivitis is that the periodontal ligament can begin to break down. And once that periodontal ligament breaks down, the tooth becomes more and more mobile. And so this would be an abnormal amount of mobility in a gomphosis. Normally, just like a suture, a gomphosis is completely immovable. So it would be classified as a synarthrosis. The next structural classification for joints would be the cartilaginous joints. And just like fibrous joints, they do not have a synovial cavity, and cartilaginous joints usually allow for little or no movement. And here the material connecting the bones together is usually going to be cartilage. And so there are 2 different types of cartilaginous joints, and these include synchondroses and symphyses. So synchondrosis is where we have 2 bones or 2 parts of a bone held together by hyaline cartilage. And normally synchondroses are completely immovable, so they would be classified as synarthroses. And the 2 examples we have here are the epiphyseal line or plate that we find in actively growing bone, and also the joint between the first rib and the sternum. So let's take a closer look at the epiphyseal plate. Remember, the epiphyseal plate was the area of actively dividing cartilage cells that eventually ossifies into bone, and it helps the bone to grow in length. As you might guess, normally there's no movement between this cartilage and the overlying bone. However, because it is a junction of cartilage to bone, we still classify it as a joint. Our second example of a synchondrosis was the joint between the sternum and the first rib. As you can see, the costal cartilage forms a joint between the sternum and the first rib, and this joint is usually completely immobile. Our next type of cartilaginous joint is something called a symphysis. A symphysis is a cartilaginous joint where the major tissue involved is fibrocartilage. However, we may have some hyaline cartilage on the articulating surfaces of the bone. Now remember, fibrocartilage was very dense, very spongy. It can resist a lot of compression. And so we tend to find fibrocartilage in between the vertebrae, and we also find it in between the pubic bones in the pubic symphysis. So let's start first with the pubic symphysis. Normally this joint is immovable, however it does become slightly movable during pregnancy when hormones will result in a breakdown of the fibrocartilage, allowing a little bit more mobility in this joint. Up top we see another example of a symphysis, and these are the fibrocartilage discs that are found in between the vertebrae. As I said previously, these discs are quite spongy. They have an enormous capacity to deal with compression. However, they're not very good at dealing with sideways movement, lateral movements. And so sometimes we can injure an intervertebral disc and cause the more jelly-like nucleus pulposus to herniate or squeeze through the outer annulus fibrosus. And this is an injury that you've probably heard of because we call it a slipped disc or herniated disc. So on the left-hand side, you can see a superior view of a normal vertebral disc. You can see it has a nice fibrous connective tissue outside, and then inside is that more liquidy area. It's sort of like the jelly inside of a donut. Now what happens as we age, the disc becomes compressed, and eventually some of that spongy material from the inside can break through the fibrous walls of the disc, and that material can then impinge on spinal nerves, which can cause a lot of pain both in the back and the extremities, and it can even cause numbness and sometimes impair bladder or bowel function. Now normally your physician would diagnose this type of disorder based on your symptoms. So if you've had back pain that's lasted for several weeks and resulted maybe from a type of injury, they might suspect that you have a herniated disc. We can only confirm this, however, if we do an MRI. Remember, MRI stands for magnetic resonance imaging, and this is a special type of imaging that's very good at looking at soft tissues. A lot of times if you go to the doctor with back pain, one of the first things they'll want to do is do an x-ray, and x-rays are good for seeing the vertebrae themselves, but on an x-ray the intervertebral discs will not appear at all. And so the gold standard here is to do an MRI. So on the left-hand side of the screen you can see a normal lumbar MRI, and the intervertebral discs are those little silver areas in between the individual vertebrae. And you can see they look nice and healthy, and they have this white to silvery inside, indicating that these discs are vital, that is, they're alive. On the other hand, take a look at the MRI on the right. Here you can see that the discs are dark, and this darkness usually indicates that they are degenerating. Some people have a genetic predisposition for degenerating discs, and as they degenerate, the probability of herniation increases dramatically. So down between L5 and S1, you can actually see a herniation that has extended beyond the vertebrae. It's extending dorsally and impinging on one of the nerve roots. And so this would result in a lot of pain for this person, again some numbness or tingling in the extremities, and it would be definitely something that we would want to think about fixing surgically. Now one surgical option for somebody with a prolapsed disc or herniated disc would be something called a laminectomy. Remember that ectomy means surgical removal, and here we're talking about surgical removal of the lamina, which were the sides of the vertebral arch. And so by removing this spinal lamina, we give the nerves and also the disc more room to decompress, and this decompression usually allows the pain to subside and results in reversal of many of the symptoms. However, because we remove the entire lamina in the spinal arch, oftentimes we have to do a fusion with adjacent vertebrae, particularly if we're doing multiple laminectomies. A less invasive procedure is something called a laminotomy. Laminotomy is surgical incision into the lamina, but we're not removing the entire lamina. Instead, we just make a small hole, and that hole allows us access to the herniated portion of the disc, and basically we do something called a microdiscectomy. That is, we remove the herniated material using a plunger or other tool, and by removing this herniated material, we decompress the spinal nerve, which should result in a reversal or subsidence of the symptoms. Now, because we're not cutting through the lamina completely, we don't really have to worry about doing a spinal fusion here. Okay, so far we've talked about fibrous joints and cartilaginous joints. The third major group of joints are going to be our synovial joints. Now, synovial joints are special because they have a fluid-filled synovial cavity which separates the articulating bones. As a result, these bones are freely movable, that is, they are diarthrotic. And examples of synovial joints include things like the knee, the elbow, the hip, the shoulder, finger, toe, wrist. Pretty much any joint that you thought of as a joint before you came into this class is a synovial joint. Synovial joints are distinguished from cartilaginous joints and fibrous joints by the presence of 5 or 6 unique features. First of these is the presence of hyaline cartilage on the articulating ends of the articulating bones, and this cartilage helps to reduce friction and also absorbs compression. Secondly, all synovial joints have an articular capsule composed of 2 different layers. There's an outer fibrous layer of connective tissue. This fibrous layer is confluent or connected to the periosteum of the bones and helps to hold the bones together. There's also an inner layer of tissue called the synovial membrane, which secretes synovial fluid. This synovial fluid accumulates in the small synovial cavity between the bones. Now, synovial fluid is pretty viscous. Its consistency is similar to that of an uncooked egg white. And like oil in an engine, this synovial fluid reduces the friction between joints. I should point out that this fluid can even be absorbed by the articular cartilages, and this is very important in reducing friction because when the cartilages are compressed, some of this excess fluid will weep out of the cartilages, further lubricating the joint. Now, synovial joints also have ligaments which serve to better unite the bones of the joint. Now remember, ligaments are structures made of fibrous connective tissue which connect bone to bone. Now, some of these ligaments are actually part of the articular capsule, called capsular ligaments, whereas some of them are located external to the capsule, called extracapsular ligaments, and some of them are located within the capsule, called intracapsular ligaments. Now, some synovial joints also contain fat pads or articular discs called menisci to further enhance the connection between bones. We'll talk about these later. And finally, all synovial joints are well innervated with sensory neurons. Some of these nerves detect pain, whereas others monitor the degree of joint stretch, a sense called proprioception. We'll talk more about these structures and others when we take a closer look at the joints of the knee and the elbow. So now we're going to talk about the different types of synovial joint movements. Now remember that synovial joints are diarthrotic joints. They are freely movable. They have a nice synovial capsule that surrounds the 2 bones, and the bones are separated by hyaline cartilage. And so there's 2 very general types of movements that we can make in synovial joints. And these include gliding movements, where the bones glide from side to side, but the angle between these bones do not change significantly. And so an example of a gliding movement would be the abduction and adduction of your wrist here. The bones are sliding past one another, but they're not changing the angle. The angular movements are much more numerous, and this results in an increase or decrease in the angle between articulating bones. So our first group of angular movements are flexion, extension, and hyperextension. Now, it's important to realize that we talk about these 3 movements relative to standard anatomical position. Now, think back, what was standard anatomical position? What did that look like? Well, remember, for people, standard anatomical position is feet on the floor, standing upright, with the palms of the hands facing outward, and your face is pointing forward. And so we talk about all these movements relative to that standard anatomical position. And normally in standard anatomical position, all your limbs are completely extended. And when you move those limbs, you may either flex them or you may hyperextend them. So flexion results in a decrease in the angle between bones, extension results in an increase in the angle between bones, and hyperextension is simply extension beyond the normal standard anatomical position. So here's two different examples of flexion and extension. Flexion, again, is the movement of a limb towards the body, and this reduces the angle between bones. And so think about the normal angle of the elbow is around 180 degrees when it's extended, and when it's flexed, it becomes something closer to 80 or 90 degrees. Now let's take a look at the knee. The knee joint is made up of three bones, the femur proximally, and the tibia and patella distally. And so when the knee is extended, the angle between the femur and the tibia and fibula is around 180 degrees, or a straight line. However, when the knee is flexed, we can get an angle that's closer to 90 degrees or even less than that. So both the elbow and knee can do flexion and extension, but normally they cannot do hyperextension because of the anatomy of the ligaments and also the articulating bones. It's also possible to flex, extend, and hyperextend the neck. So think about if you were going to nod your head yes. This is called flexion because it reduces the angle between the neck and the sternum. Extension is the normal anatomical position, that is with your head upright, and hyperextension is when you lean your head back beyond the normal anatomical position. And hyperextension can be painful if it happens quite suddenly. For example, if you're hit from behind in a car, you can get something called whiplash, which results from sudden and violent hyperextension of the cervical vertebrae. So flexion, extension, and hyperextension are also possible in the ball and socket joints, that is the hip joint and also the shoulder joint. So when you flex the hip, you put your thigh forward, and when you extend it, you're standing on the ground, and hyperextend it, you're putting it in back of you. Same with the arms here. So flexion is to put your arms up zombie-like. Extension is normal anatomical position, and if you're skiing and put the ski poles behind you, that would be an example of hyperextension. So ball and socket joints have a very wide range of motion when compared to hinge joints like the knee and also the elbow. So look at this. We can even flex, extend, and hyperextend the phalanges in the wrist. So flexion is when the fingers come inward. For example, you're telling somebody to back the car up. Extension is when your fingers are in normal anatomical position, and you can hyperextend them just a little bit and also hyperextend the wrist. Now, on the other hand, abduction and adduction are two opposite movements that have to do with the movement of the limbs away from the midline of the body. So abduction is the movement of the arm or other limbs away from the midline of the body. And the way I like to remember this is when you abduct something, you take it away, just like when you abduct a baby, you take the baby away. On the other hand, adduction is the movement of a bone towards the midline of the body. So when you put your arms back down during a jumping jack, that is called adduction. And a good way to remember this is that you're adding ADD, the limbs back to the body. In addition to being able to abduct and adduct the shoulder and hip, we can also abduct and adduct the fingers of the hand. So on the right hand side of the picture, you can see that the fingers are adducted, and on the left hand side of the picture, you can see the fingers are abducted. That is, they are moved away from the midline of the body. And then, of course, with our ball and socket joints, that is our hip joint and our elbow joints, we can do something called circumduction. That is, we can move the distal end of our appendage in a circle. And so when you do the hokey pokey and you turn yourself around, you're doing circumduction. On the other hand, rotation is when a bone revolves around its own longitudinal axis. For example, the atlantoaxial joint, which is the joint between C1 and C2, allows us to shake our head no. This is an example of rotation. We can also, to some extent, rotate the lower appendages, that is the thigh. So it's possible to laterally rotate the hip just a bit and also medially rotate the hip. Now we're going to go look at some special movements of body parts, and the first part we're going to look at is the foot. So the foot can do some pretty cool stuff. One of these things is called inversion, and inversion is when you stand on the side of your feet, forcing your big toe to elevate off the ground. On the other hand, eversion is when we put our big toe on the ground and face our little toes out and pull them off the ground, and that's eversion. And of course we can point our toe either to the sky or to the ground. And so dorsiflexion is when you point your toes in a dorsal direction, that is, pointing them upwards. On the other hand, plantar flexion is when you point the toes down. I like to think that you're pointing the toes towards the ground where you would plant your crops. For example, if you ever see really good ballerinas that can stand on tippy toe, they're doing a very extreme version of plantar flexion. Now the jaw is simply an amazing joint that can do several different types of movement. First of all, we can elevate our jaw, and so when we close our jaw to chew on food, this is an example of elevation. On the other hand, when you put your jaw down, this is an example of depression. And so if you're sitting there with your mouth agape, your mandible is depressed. We can also protract and retract our jaw. So protraction is when you face your jaw forward. And this is kind of what my wife looks like if I come home and forget to pick up the groceries or something like that. That jaw is jutting out and very protracted. On the other hand, retraction is where we pull the mandible or lower jaw underneath the upper jaw. And so as a result, you look kind of like some kind of toothless hillbilly. Now the reason that all these different movements are important is the function of the jaws, of course, is to masticate and grind the food. And this doesn't simply involve some up and down movement, but it also involves some forward and backwards movement. Think about what happens when you're chewing on some very hard or crumbly food. Think about eating a carrot. Where in your mouth are you going to chew on that carrot? Well, chances are you're going to use your incisors to initially bite off that carrot. And in the process of biting that carrot, you will protract your lower jaw. But as you chew that carrot, you will do a little bit of elevation and depression and also some side-to-side motion. And so the flexibility of the jaw is very important in its primary function of being able to masticate food so that it can be easily swallowed. Now we're going to go on to some of these specialized hand movements, and these include supination and pronation. And again, these are two very opposite movements. So supination is when the palm of the hand is facing anteriorly. And so a good way to remember this is that you would want your palm facing anterior or upward if you were going to hold a bowl of soup, supination. On the other hand, you would want to pronate your palm, that is, face it posteriorly if you're going to dribble a basketball, if you were a professional basketball player. So supination, the hand is anterior or up, and pronation, the palm is posterior or down. Another special movement of the hand is something called opposition. And opposition is simply our ability to touch our fingertips using our thumb. And we're able to oppose our thumb because we have a saddle joint between the first metacarpal and the trapezium of the wrist. And this is important because opposition allows us to grasp things and manipulate tools. And so think about all the different types of artwork and architecture and engineering in the world. Most of this would not be possible if we were not able to oppose our thumbs. Now humans and primates are pretty unique in their ability to oppose their thumbs because most vertebrates are not able to oppose their thumbs. And I actually consider this a good thing. For example, think of what could happen if your dog or cat had an opposable thumb. Well, I can't say for sure, but I'm pretty sure it would be chaos. For one, my dog would be going to the refrigerator, pulling out all the food, going to the cupboards, and eating himself sick. I'd have to put locks on everything. And of course, your cats would be opening their own cans of food, and your dogs would probably be using the computer, looking at doggy pornography or something like that. So it is important to realize that humans and primates are unique in having this ability to oppose their thumb, which allows us to manipulate tools. So several factors affect the range of motion of synovial joints. And range of motion is a very important measurement, not just for clinicians, but also for us in lab. Next week we're going to be measuring the range of motion of various joints in the body and comparing how range of motion changes based on gender and also based on exercise. So there are 5 or 6 things that can affect the range of motion of a joint. First of these is the structure and shape of the articulating bones. So let's think, for example, about the elbow joint. What 3 bones are articulating? Well, the humerus proximally is articulating with the radius and ulna. and think about the movements that the elbow can do. We can flex it, we can extend it, but we can only extend it so far. And that's because the olecranon process, which is part of the ulna, fits into the olecranon fossa on the humerus and stops that elbow from hyperextending. Now you would think that the bones themselves would be the main factor determining the range of motion of a joint, but usually it's actually not. Oftentimes the strength and tautness of the joint ligaments and also the muscle tendons is most important. And so we have somebody that doesn't do a whole lot of stretching or get a whole lot of exercise, chances are they're going to have a much lower range of motion than somebody that gets a lot of exercise and also does a lot of stretching. Some areas of the body, for example the hip, we have lots and lots of tight ligaments around the hip that prevents it from luxating or moving out of the cavity, and so these ligaments really do restrict the range of motion. Another thing that can affect the range of motion, of course, is injuries and disease. And towards the end of this lecture, we'll talk about diseases like osteoarthritis and rheumatoid arthritis, and these can definitely reduce the range of motion. And finally, hormones are an important factor affecting range of motion, particularly when we're talking about pregnant females. In the latter stages of pregnancy, there will be some hormones that will make the pubic symphysis a little bit more mobile, which will give us more clearance for the birth of that fetus. And finally, the last two things that affect range of motion are both disuse and aging. You obviously know that as we age, our range of motion of most joints is going to go down, and part of this has to do with loss of muscle tone, but also with disuse. So if a joint is not used frequently, its range of motion will go down. And so if you're not somebody that gets a lot of exercise or does a lot of stretching, you can expect your range of motion to go down steadily throughout your lifetime. And I should point out that disuse is probably one of the most important factors that affects range of motion of a joint. So think about somebody that comes into a hospital for something like a hip replacement. Now it used to be 20 years ago they would have that hip replacement and they would be in bed for several days before we would even think about having them walk around. Now within usually 6 to 12 hours of a major hip replacement, we're going to have that patient walking around, because now we realize that the sooner that they get mobile, the greater chance they're going to have of getting back their original range of motion. Whereas if they remain in bed all the time, their range of motion is not going to increase. In fact, it may even go down. So now that we've had a brief overview of the different types of movement possible with synovial joints, we're going to take a look at the 6 major types of synovial joints. And these include planar joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints. Our first joint is a planar joint. A planar joint is where we have two different flat bones that are gliding over each other. There's no angular movement between the bones, only gliding. And so examples of planar joints include things like the intercarpal joints, the wrist joints, the intertarsal joints found at the ankle, and also the joints of the vertebral articular surfaces. And so again, planar joints simply allow gliding. There's no angular movement permitted. On the other hand, in a hinge joint, we have a convex or rounded surface that is going into a concave or depressed surface. And so an example of a hinge joint here would be the elbow joint. Here we have the trochlea, which is rounded, going into the trochlear notch of the ulna, which is concave. And so the movement allowed by hinge joints like the elbow is uniaxial. And by uniaxial, I mean that the limb can only move in one plane. So flexion is when our elbow is flexed and it's close to our humerus. Extension is when the angle between the humerus and the radius and ulna is about 180 degrees. And we can do a little bit of hyperextension, particularly if you're not a very muscular person. You might be able to go a few degrees beyond that. But even if you can hyperextend, it's important to realize that this movement, flexion, extension, and hyperextension, is all in one plane or axis. So we say that the movement here is uniaxial. Another type of joint is something called a pivot joint. Here we have a rounded surface of a bone that is articulating with a ring that's usually formed by connective tissue or ligament. And so the movement here allows for uniaxial rotation around a longitudinal axis. And the examples that we have are the radial ulnar joint, that is the joint between the radius and ulna that allows supination and pronation, and also the atlantoaxial joint. And that was the joint we had between the first two cervical vertebrae that allowed us to turn our head no. And remember, the unique structure that we had on the second cervical vertebrae was the dens. The dens was that rod of bone that protrudes from the second cervical vertebra, the axis, and goes up through the first cervical vertebra, the atlas. Another type of joint is something called a condylar joint. Remember before we said a condyle was a rounded structure, and so here a condylar joint is where we have a round convex bone that's going into a round concave cavity. And so examples of a condylar joint include things like the knuckles or interphalangeal joints and also parts of the wrist joint. And so movements permitted by the condylar joints are biaxial. Think about the movements you can do with your phalanges. You can do flexion and extension. You can also do a little bit of abduction and adduction and maybe even some circumduction. So this is an example of a biaxial joint. Another example of a biaxial joint is a saddle joint. In a saddle joint, we have a deeply convex process going into a deeply concave receptacle, and this allows biaxial movement. The example of a saddle joint here is the carpometacarpal joint of the thumb. And remember, this saddle joint allowed us to do some pretty unique things, such as opposition of the thumb, that is, ability to touch the fingertips with the tip of the thumb. And of course, opposition allows us to grasp tools and things like that, but we can also do abduction of the thumb, we can flex the thumb, and of course, oppose the thumb. And our last joint here is something called a ball and socket joint. And ball and socket joints include things like the shoulder joint and also the hip joint. The hip joint is a much deeper socket than the shoulder joint, but both of them allow multi-axial movement. So think about the movements you can do with your hip and your shoulder. You can abduct them, that is, take them away from the midline. You can adduct them, put them back. You can flex them, put them forward, and extend and hyperextend them. And of course, then you can do rotation and even a little bit of circumduction. And so this is truly a multi-axial joint because it allows movements in 3 planes.